Hey everybody, we're going to continue on with the concept of perfusion, and this time we're going to speak directly about hypertension. Objectives of this session, we're going to talk about what hypertension is and how it's classified, talk about how cardiac output, peripheral resistance, and blood volume affect blood pressure. We'll talk about baroreceptors, chemoreceptors, emotions, and hormones that influence BP. We're going to talk about the long-term consequences of untreated hypertension. We really need to talk about therapeutic lifestyle changes and the management of hypertension. We'll talk about primary and secondary pharmacological measures used to treat high blood pressure. We will discuss prototype meds focusing on some specific classes, and then ultimately use the nursing process to discuss how we will care and educate our clients. So hypertension or high blood pressure is a consistent elevation of systemic arterial blood pressure. And this can vary with our age. A lot of times you'll notice as clients become older, they start to have problems with high blood pressure. Hypertension is also the most common form of cardiovascular disease, and it's associated with more than 348,000 deaths in the United States every year. There's a couple of factors that are responsible for blood pressure. So the first one being cardiac output. So this is the volume of blood pumped per minute. It's determined by stroke volume and heart rate. There are medications that can affect cardiac output, stroke volume, and then the heart rate, and this is all going to affect blood pressure. You also need to think about peripheral resistance. Now, this is the friction in the arteries as blood flows through the vascular system. So the greater the resistance in the arteries the higher the blood pressure may be. There are medications that can affect vascular smooth muscle, and these may lower or raise blood pressure depending on what you need. The autonomic nervous system also plays a role in regulating this peripheral resistance, and this could be central or autonomic nervous system. Those are going to come into effect with vasomotor center, baroreceptors, and chemoreceptors. Blood volume also needs to be considered, and this is the total amount of blood in the vascular system. Increased blood volume is subsequently going to have an increase in blood pressure. There are medications that can affect the blood volume, and it can lower or raise blood pressure as needed. So for example, if you wanted the blood pressure to be lowered with blood volume, then we would administer medications like diuretics. So a few other things that can affect blood pressure, one of them being emotions. Things like stress and anger can increase blood pressure, and depression and lethargy can have a decrease on blood pressure. Hormones also can play and have a role with blood pressure. Natural hormones affect blood pressure daily. So for example, epinephrine and norepinephrine raise blood pressure. Antidiuretic hormones can also raise blood pressure by raising blood volume. And the renin-angiotensin-aldosterone system is a primary homeostatic mechanism for controlling blood pressure. So primary hypertension, this has no identifiable cause. However, secondary hypertension, the cause can be identified. Some examples of secondary hypertension or causes of it could be Cushing's syndrome, hyperthyroidism, chronic renal disease, and certain medications. Target organs are affected by untreated hypertension, and these can include heart, brain, kidneys, and the retina. Disease progression to organs could lead to heart failure, transient ischemic attacks, or other cerebral vascular accidents, ultimate renal failure, visual impairment, and blindness. So ultimately what we want to do is either prevent hypertension in our clients or manage it through non-pharmacological measures. So some of the things that you're going to want to do as the nurse is, of course, teach your clients to limit alcohol intake. We're going to want them on a low sodium, probably low fat diet. One very common is the DASH diet. That's going to help also reduce saturated fats and cholesterol. We always want clients to increase their physical activity and maintain optimal weight, reducing stress, because remember, emotions can come into play, and ultimately and forever ask them to stop smoking. Pharmacological wise, there's usually some first line meds that providers are going to do first, and then there's second line medications. So typically, when clients do have high blood pressure and they start going to a pharmacological measure, it would not be uncommon for a client to be on a diuretic, either a loop diuretic or a thiazide diuretic. ACE inhibitors are pretty common, as well as ARBs and calcium channel blockers. For this presentation for first line, we're going to focus on the loop and thiazide diuretics. Now, sometimes those medications don't work. Sometimes they have adverse reactions or symptoms and clients don't tolerate them well. Then they'd probably go to second line medications like your beta adrenergic blockers, those alpha 1s and alpha 2s. Ultimately, if hypertension becomes severe, they may need a direct acting vasodilator, and we're going to focus that on this presentation as part of our prototype drugs. Also, you want to consider a couple of things just to reiterate. Always make sure that you assess the patient's lifestyle. We have to ask about those dietary habits, their exercise and activity regimen, and any other medications as always. Again, just let's reiterate, we want them to try to lose weight, limit foods high in fat and sodium, limit that tobacco and alcohol, and if they can, start doing some type of exercise. Your role as the nurse is going to make sure that you complete a health history, and it needs to be very thorough. Again, vital signs need to get your baselines and any trends. You're going to do your head to toe assessment, looking for anything that could be manifesting with high blood pressure, any symptoms, and then always looking at blood, urine specimens for analysis. All right, so our first prototype drug, we're going to start off with one that's very, very common, and that is furosemide or Lasix. This is a diuretic, and it is a loop diuretic. This is in an overview in this chapter, but the actual prototype drug box is located in chapter 24. So I'd like you to go ahead and kind of pull that up so we can follow along. One of the key assessments that you want to monitor with patients on loop diuretics, and this is really important, these loop diuretics can be considered potassium wasting. So clients could have severe potassium loss, hypokalemia, hypotension, hearing loss, because this particular medication is ototoxic. And we also need to make sure we monitor their glucose and uric acid levels. And we'll talk a little bit more about that as we go along. Lasix is used often in the treatment of heart failure that we discussed earlier. It has the ability to remove large amounts of excess fluid from a patient in a very short period of time. When you give this medication IV, diuresis can begin within 5 minutes. And this is going to help patients have a quick relief of any manifestations. Like, so for example, if a client's in heart failure and they are having fluid buildup in the lungs, this would be a very common medication that we would give IV. Furosemide acts by preventing the reabsorption of sodium and chloride in the loop of Henle region of the nephrons in the kidneys. Excuse me. Compared with other diuretics, Lasix is beneficial when cardiac output and renal flow are severely diminished, which is why probably this med is located in chapter 4 with renal failure. Some administration alerts and considerations. You always need to check the client's potassium level before administration. If the potassium levels are low, which means you need to know you're normal, you need to notify the healthcare provider immediately before you administer. Older adults, we always need to be mindful, may need a lower dose. Remember, their kidneys don't work as well, so just be mindful if you are dealing with geriatric clients. Some adverse effects that we need to consider. Like many diuretics, this has the potential for severe electrolyte imbalances, most importantly, which is hypokalemia. Because furosemide is so effective, fluid loss must be carefully monitored to prevent dehydration and hypotension. So remember, it acts pretty quickly. They're going to have quick relief. So you want to make sure that you are watching strict I's and O's, watching their vital signs, and making sure they do not become dehydrated or hypotensive. This medication or the result of hypovolemia again causes orthostatic hypotension and syncope, and to restrate this medication is ototoxic, so we need to be mindful of teaching our clients that this can cause hearing damage. This medication does have a black box warning. It's a very potent diuretic that, if given in excess amounts, may lead to profound diuresis with water and electrolyte depletion. So we need careful supervision, especially if you're giving it through the IV route. Contraindications are hypersensitivity to either Lasix itself or sulfonamides. Clients could become anuric. This could cause hepatic coma, or we need to be mindful of clients in hepatic coma, and again, severe fluid or electrolyte depletion. For drug-drug interactions, we need to be mindful because hypokalemia is so prevalent. You always need to monitor for cardiac dysrhythmias, especially if your client's taking cardiac glycosides like DIG. Combination therapy with DIG must be monitored carefully. You want to make sure that you don't give this medication with aminoglycoside antibiotics, because this is going to have a possible additive nephrotoxic and ototoxic combination. So not only could it damage hearing even further, but also kidney function. Be mindful with corticosteroids and other potassium depleting drugs. Again, this causes hypokalemia. And Lasix may diminish hypoglycemic effects of sulfonylureas and insulin, so be very careful with diabetic clients. And it's not uncommon for clients to have hypertension, be on a loop diuretic, as well as have diabetes and be on either an oral medication or insulin. Lab tests, I hope you are already jumping out of the chair and saying, let me check that potassium level. I got to be mindful, diabetic or not, look at their blood glucose. Always need to look at bun levels because we need to monitor their kidney function. Always look at cholesterol levels, triglycerides, and other electrolytes as well, but we need to focus definitely on that potassium. Need to be mindful for herbal and food. Hawthorn and herbal can result in hypotensive effects. Ginseng may decrease the effectiveness of Lasix. High sodium intake is also going to reduce the effectiveness of diuretics, which is why we want clients on a low sodium diet. Treatment for overdose. Overdose will result in hypotension and severe fluid and electrolyte loss. The treatment is supportive, so what we're going to do is we're probably going to give them replacement fluids, maybe a bolus. We may need to administer potassium replacement or other electrolytes, and probably, if in the event we needed to, we'd have to give a vasopressor. All right, so for our next prototype drug, we're going to talk about hydrochlorothiazide, or HCTZ. Again, the prototype box is located in chapter 24. Before we begin, we want to kind of overview some key assessment and monitoring points for thiazide-like diuretics. Always monitor laboratory values to include a CBC, electrolytes. We need to monitor blood glucose and uric acid levels. This medication, you may possibly need to increase potassium in the diet or with supplements. Thiazide diuretics, HCTZ especially, is one of the largest, most commonly prescribed classes of diuretics. What this does is it blocks sodium reabsorption and increases potassium and water excretion. It's indicated for use in edema associated with the heart, hepatic, and renal failure. This is less effective than the loop diuretics, and it is not as effective in patients with severe renal failure. It's, again, one of the most widely prescribed diuretics for hypertension. It produces few serious adverse effects, and it can produce about a 10 to 20 millimeter of mercury reduction in the blood pressure. Patients with severe hypertension or a compelling condition may require the addition of a second drug from a different class to control a disease. And there's lots of combination drugs. So, for example, when I was starting to have high blood pressure and I went to the doctor, and the very first thing he put me on was a combo medication, which was lisinopril, an ACE inhibitor, and HCTZ. So it kind of affected both of those areas. So it's not uncommon to see HCTZ in what I call a combination med. It's approved to treat ascites as well, edema, heart failure, and high blood pressure. And again, HCTZ is a common abbreviation that we recognize with this. However, please be mindful of the use of abbreviations because it can be confused with hydrocortisone. This medication is going to act in the kidney tubule to decrease reabsorption of sodium. It's going to block some reabsorption, help with urine output. Excuse me. And the volume of urine produced is directly proportional to the amount of sodium reabsorption that's blocked by this diuretic. One thing we need to be considerate about when we administer this medication, and probably for Lasix too, because these medications are diuretics, we really want to try to give them to the clients earlier on in the day because they're going to increase their urine output, so we don't want them to have nocturia. HCTZ is well tolerated and exhibits few serious adverse effects, the most common being potential electrolyte imbalances due to loss of potassium and sodium. Hypokalemia, again, may cause cardiac conduction abnormalities. Patients are usually instructed to increase their potassium intake just as a precaution. This medication may precipitate gout due to its tendencies to cause hyperuricemia. So we always got to look at that uric acid. Contraindications with this medication include anuria and a prior hypersensitivity to thiazides or sulfonamides. HCTZ is contraindicated in preeclampsia or other pregnancy-induced hypertension. Interactions, when given concurrently with other antihypertensives, either in a combo drug or maybe I'm on an ACE inhibitor standalone, I'm on a thiazide diuretic, I'm on a beta adrenergic blocker, it's possible. You just know this is going to potentiate the blood pressure, so we need to be mindful for hypotension. Thiazides can also reduce the effectiveness of anticoagulants, sulfonylureas, and anti-diabetic drugs, including insulin. Clients that are on HCTZ, this medication can increase the risk of renal toxicity from NSAIDs, so please do a thorough medication history and ask about the over-the-counter medications. If they're on a steroid as well, this could increase potassium loss. And we always need to be mindful if we're on thiazide diuretics when in combination with digoxin. Lab tests you want to monitor for, again, are glucose, cholesterol, triglycerides, calcium levels, mag, potassium, and sodium. With regard to herbal and food, ginkgo biloba may produce a paradoxical increase in blood pressure, and we need to be mindful with hawthorn as well because this can make the blood pressure go even lower. If there is an overdose with this medication, it's usually manifested as electrolyte depletion, which is treated with infusions for magnesium, or not magnesium specific, but either potassium, mag, sodium, whatever the electrolyte imbalance is, they'll correct it with that. Also, fluids may be administered just to increase volume, and which would subsequently increase the blood pressure. So when we're talking about antihypertensives, we do want to discuss hydralazine or apresiline. This is a direct-acting vasodilator. Some key assessments that we want to do and monitoring if we're administering this medication is if we're giving it an emergent situation, which is predominantly when we give it if they're severely hypertensive, we want to make sure that we monitor vital signs continuously to include pulse oximetry and as well have constant EKG monitoring, most likely either probably by telemetry. This particular medication was one of the first oral antihypertensive drugs marketed. It's going to act with vasodilation on the arterial smooth muscle. It does not affect the veins. Um, Typically, therapy is given in low doses and gradually increased until the therapeutic effect is achieved. However, after time, clients can develop a tolerance to the drug, and then dosages will have to be adjusted again. This medication has pretty much been replaced by other antihypertensives, mainly due to safety concerns. However, this is primarily used in the treatment of hypertensive emergencies. Adverse effects, this can cause headache, reflex tachycardia, palpitations, flushing, nausea, and diarrhea. But they may resolve as the therapy progresses if they're taking this orally. Clients on hydralazine often receive a beta-adrenergic blocker to kind of counter effect that reflex tachycardia. Sodium and fluid retention is a potentially serious adverse effect. And because of these adverse effects, the use of hydralazine is limited mainly to patients whose condition cannot be controlled with other, more safer antihypertensives. Contraindications. Because of this effect on the heart, hydralazine is contraindicated in patients with angina, MI, or tachycardia. Drug-drug interactions, hydralazine in combination with other hypertensives, of course, can cause severe hypotension, and this includes all drug classes used as antihypertensives. NSAIDs may decrease the action of hydralazine. Regarding lab tests, this medication may produce a false positive Coombs test. We need to be mindful of hawthorn when used with this medication. So one connection you can make with all three of the medications we discussed is when it comes to herbal, we don't want clients on hawthorn. With regard to treatment or overdose, the most likely sign of overdose is hypotension, which is treated with either IV infusion of fluids like a bolus or a vasopressor. So for our nursing process, I'm going to go over a few key points, and you might find these very familiar to the previous presentations when we talked about ACE inhibitors and beta-adrenergic blockers. For assessment, of course, take the patient's blood pressure and get a baseline. You need to assess the client's height and weight because we're looking to see if they're overweight. Always obtain blood and urine samples that are ordered by the physician. We need to get a thorough history, including their lifestyle, current medications, and dietary habits. And always assess the patient's and family's knowledge of high blood pressure and the medication regime that they're on. Common nursing diagnoses associated: decreased cardiac output related to excessive or prolonged systemic vascular resistance, deficient knowledge, activity intolerance, and possible sexual dysfunction related to the side effects of medications. When we're planning, we want to help our clients establish goals and outcomes. Some common goals or outcomes would be exhibit a reduction in high blood pressure. Clients should be able to explain hypertension and their needed medications, and they should be able to verbalize ability to follow prescribed therapy. When we're thinking about implementation, we want to always encourage compliance and, as always, provide education regarding the specific medications. When we're evaluating, we want to have the ideal outcome based on those goals, and hopefully that is lowered blood pressure with limited side effects. The patient is able to verbalize the importance of taking their medications. So this is really interesting. So for teaching and education, basically we kind of covered the things that you would teach as we went along with the prototype drugs. However, if you need a little bit of a review, go back to the presentation when we talked about congestive heart failure, and you can kind of look at those teaching points for there because they are very similar across the board. Basically, we want to talk about reducing blood pressure, teach them non-pharmacological measures that we discussed earlier, emergence, when to call the provider, and always make sure we prevent knowledge deficit. If you have any questions regarding this presentation, please post them in the Prep for Exam 3 discussion forum of your Blackboard course, and have a wonderful day.